Bradycardia, your third module for the Advanced Cardiac Life Support Training course of the Philippine Heart Association. Upon completion of this module, you should be able to recognize unstable and symptomatic bradycardia, manage patients with symptomatic bradycardia, and acquire basic knowledge in pacing. Bradycardia is defined as a heart rate of less than 60 beats per minute and is usually asymptomatic. However, when bradycardia is the cause of symptoms, the rate is generally less than 50 beats per minute, which is the working definition of bradycardia used in the algorithm. Bradycardias include sinus bradycardia, sinus pause, and sinus rhythms with heart blocks. It can also occur with any rhythm for which the rate is inappropriately slow. The following are slow rhythms we often encounter in practice. Let's go over them one by one. Sinus bradycardia is appreciated on the ECG or cardiac monitor when there is a normal upright P wave in lead 2, preceding every QRS complex with a ventricular rate of less than 60 beats per minute. Sinus bradycardia is frequently asymptomatic. Heart rates of 40 to 50 beats per minute can be tolerated well in some individuals. A sinus pause or arrest is defined as a transient absence of sinus P waves on the electrocardiogram that may last from 2 seconds to several minutes. This abnormality is an alteration in discharge by the sinoatrial pacemaker, and as a result, the interval between the previous beat and the next beat is less than twice the normal interval. In junctional rhythm, impulses come from the AV node. The P wave is inverted or buried within the QRS or follows the QRS. The rate is low, usually at around the range of 40 to less than 60 beats per minute, and the QRS complexes are narrow. On the other hand, in idioventricular rhythm, the impulse comes from the ventricles. The P waves are absent, and the QRS complexes are wide, usually more than 0.10 seconds. The T wave is opposite in direction to the QRS complex, with a rate of less than 40 beats per minute. Heart blocks occur when the cardiac electric impulse is delayed or blocked within the AV node, the bundle of His, or the Purkinje system. Common heart block rhythms that you may encounter are the following. First is second-degree AV block Mobitz type 1. The PR intervals will lengthen progressively with each beat until a QRS complex is missing, called a dropped beat. After this dropped beat, the cycle of lengthening PR intervals resumes until another dropped beat occurs. With Mobitz type 2 blocks, the impulse is blocked in the bundle of His. The PR interval is fixed, which will intermittently be followed by a dropped beat. With complete heart block, no atrial impulses are transmitted to the ventricles. As a result, the ventricles generate an escape impulse, which is independent of the atrial beat, causing an atrioventricular dissociation. In most cases, the atria will beat at 60 to 100 beats per minute, while the ventricles asynchronously beat at 30 to 45 beats per minute. Again, to review, second-degree AV block Mobitz type 1 has progressive lengthening of PR interval with intermittent drop beats. Second-degree AV block Mobitz type 2, the PR interval is fixed with intermittent drop beats, while your complete heart block has no recognizable consistent relationship between atrial and ventricular activity, or what is called as atrioventricular dissociation. Now that you are familiar with the different rhythms that may present as bradycardia, the next question is, when do we say that patients with bradycardia are unstable or symptomatic? Patients with bradycardia who are asymptomatic do not necessarily require treatment unless there is suspicion that the rhythm is likely to progress to symptoms or become life-threatening. If bradycardia produces signs and symptoms of instability, like acute altered mental status, ischemic chest discomfort, acute heart failure, hypotension, or other signs of shock, the patient should receive immediate treatment. The first step in the general ACLS algorithm is to identify the rhythm correctly. Once the rhythm is identified, we should check for the presence of pulse within 10 seconds. Because hypoxemia is a common cause of bradycardia, your initial evaluation should focus on signs of increased work of breathing like tachypnea, intercostal and suprasternal retractions, and paradoxical abdominal breathing. You should also determine oxyhemoglobin saturation with pulse oximeters. Equally important, you should maintain patient airway and breathing as necessary. If oxygenation is inadequate or the patient shows signs of increased work of breathing, provide supplementary oxygen. Attach a monitor to the patient and evaluate blood pressure. Establish IV access. If possible, obtain a 12-lead ECG to better define the rhythm. Do not delay therapy. While initiating treatment, evaluate the patient's clinical status and identify potentially reversible causes. You must identify signs and symptoms of poor perfusion and determine if those signs are likely to be caused by the bradycardia. If the signs and symptoms are not due to bradycardia, you should reassess the underlying cause of the patient's symptoms. If the bradycardia is suspected to be the cause of the symptoms, you should immediately proceed to administering treatment to the patient. Atropine remains a first-line drug for acute symptomatic bradycardia. Clinical trials in adults show that IV atropine improved heart rate, symptoms and signs associated with bradycardia. The recommended atropine dose for bradycardia is 1 mg IV every 3 to 5 minutes to a maximum total dose of 3 mg. If atropine is ineffective, you may infuse dopamine in patients with symptomatic bradycardia, particularly if patient also presents with hypotension, in which atropine may be inappropriate, or after atropine fails. You may start dopamine infusion at 5 to 20 micrograms per kilogram per minute. You may also use epinephrine infusion. Begin infusion at 2 to 10 micrograms per minute. Transcutaneous pacing should be considered in patients with severe symptoms or hemodynamic compromise while preparing the patient for transvenous pacing. The patient should be prepared for transvenous pacing, or TVP, and expert consultation should be obtained. Now let's go to cardiac pacing. Transvenous cardiac pacing is a Class 2A recommendation for patients with unstable bradycardia, such as sinus node dysfunction, AV blocks, and those refractory to medical therapy. Transcutaneous pacing, on the other hand, is a Class 2B recommendation to be used as a bridge for transvenous pacing for severe symptoms and hemodynamic compromise. Pacing is not recommended in patients with stable bradycardia and asystolic cardiac arrest. There are two types of pacing. One is transcutaneous pacing, in which the heart is stimulated with externally applied cutaneous electrodes that deliver electrical impulses. The picture shows the placement of the electrodes: anterior, lateral, or anterior, posterior. These electrodes are connected to the machine. In patients with severe hypothermia, cardiac pacing is relatively contraindicated. In these patients, bradycardia may be a physiologic phenomenon resulting from decreased metabolic rate. Also, as body temperature drops, the ventricles become more prone to fibrillation and more resistant to defibrillation. The other type is transvenous pacing, a procedure done by either an interventional cardiologist, electrophysiologist, or intensivist. This is more invasive, which consists of endocardial stimulation of the right atrium or ventricle or both via an electrode introduced into a central vein, either the internal jugular, subclavian, or femoral vein. This is connected to a generator box. This is how you connect your patient to a transcutaneous pacemaker. Step 1. Apply the pacing pads to either of the two positions and consider sedation. Step 2. Turn the monitor on and set it to pacing mode or pace by rotating the button. Step 3. Set the pacing rate at 80 beats per minute using the rate button. Step 4. Set the output from the lowest and increase until capture is achieved. Electrical capture occurs when a pacing stimulus leads to depolarization of the ventricles. It is confirmed by ECG changes typical of ventricular complexes, namely pacemaker spikes, a widening of the QRS complex, and a tall, broad T wave opposite the QRS. Step 5. Confirm mechanical capture with femoral pulse. Carotid pulse for assessment of circulation is not used because transcutaneous pacing can create muscular movements that may feel like a carotid pulse. Let's now go to a sample case. You are presented with a 65-year-old male, office clerk, known hypertensive, who came into the emergency room with a chief complaint of dizziness. Vital signs showed a blood pressure of 60 millimeters mercury, a heart rate of 35 beats per minute, a respiratory rate of 34 cycles per minute, and an O2 sat of 92%. The question is the patient stable or unstable? The patient is unstable. You are correct. Good job. A 12-lead ECG was done that showed this. What is this rhythm? The answer is sinus pause. After a regularly occurring PQRS complex, the SA node fails to fire, thus a sinus pause is appreciated. Did you get it? Good job. What is the next step? A. Give epinephrine IV. B. Give atropine 1 mg IV. C. Do CPR. Or D. Observe and monitor patient. The answer is B. Give atropine 1 mg IV. As previously mentioned, atropine remains the first-line drug for acute symptomatic bradycardia. Did you get it right? Good job! You gave 3 doses of atropine and the rhythm became this. Can you identify the rhythm? The answer is complete heart block, because the rate is low with no recognizable consistent relationship between atrial and ventricular activity, which is characteristic of atrioventricular dissociation. Did you get it? Good job! What is the next step? A. Start epinephrine infusion. B. Start dopamine infusion. C. Transcutaneous pacing. D. Refer for expert consultation. Or E. All of the above. The answer is all of the above. If atropine is ineffective, you may start dopamine or epinephrine as infusion or transcutaneous pacing. The patient should be prepared for transcutaneous or transvenous pacing, and expert consultation should be obtained. If you answered correctly, then good job! After expert consultation, there was a change in the rhythm. Can you identify the rhythm? The answer is pacemaker rhythm, because of the presence of the pacemaker spikes and widened QRS complexes when transcutaneous pacing was initiated. Did you get it? Good job! To summarize the module, always remember the following. When bradycardia produces signs and symptoms of instability, immediate intervention is indicated. Atropine is a first-line drug for acute symptomatic bradycardia. The recommended atropine dose for bradycardia is 1 mg IV every 3 to 5 minutes to a maximum total dose of 3 mg. Dopamine and epinephrine infusion may be used if atropine fails. And lastly, transcutaneous pacing should be considered in patients with severe symptoms or hemodynamic compromise while preparing the patient for transvenous pacing. Thank you for listening. You are now ready to proceed to the next module, which is on tachycardia.